ready to learn about heart failure. This will be a two-part lecture. So today we're just going to talk about the pathophysiology of heart failure, what it means, what are the different kinds of varieties of heart failure that we might encounter, because our treatments are going to be very different depending on what we are dealing with. Okay, heart failure, although we try to kind of globalize that term, it really is an umbrella term for lots of different versions of heart failure, and you got to know what you're dealing with in your patient because the management is going to be completely different. Tomorrow we'll actually talk about the management. We'll walk through the ACC, AHA algorithms on how to treat heart failure. So hopefully you'll understand after today's lecture why we do what we do when it comes to the management side of things. Okay. So let's just do one quick check on learning from yesterday's lecture related to the valvular diseases. Okay. This one is, which of the following valvular condition presents primarily as a pressure load to the left ventricle? So pressure, not volume. What are your thoughts? Hearing whispers of C, Charlie, is that right? Yeah. Okay, correct. So mitral stenosis is a pressure problem for the left atria, not the left ventricle, so that's why that one is wrong. Mitral regurg is and as well as aortic regurg are volume problems, right? So that's why those two are not correct answers. So it leaves us with aortic stenosis. And remember, aortic stenosis is there's a lot more pressure that has to be exerted in order to actually open that valve up to allow that flow of blood to leave the left ventricle. So that's why aortic stenosis is a pressure load problem. All right, so talking about heart failure, there's a couple of definitions that may kind of shed some light on what exactly is going on and what we mean by heart failure. Okay, our textbook, Lilly, defines heart failure as being present when the heart is unable to pump blood forward, so it's a forward problem, at a sufficient rate to meet the metabolic demands of the body, or is able to do so only if the cardiac filling pressures are abnormally high. So basically there's a compensatory kind of change where the pressure goes up too high to try to support that forward cardiac output, but it starts having problems, or it starts causing additional problems because that pressure is so high. The ACC, the AHA, their definition I think makes a little more sense. There's not as many caveats to it, but they define it as a complex clinical syndrome with symptoms and signs that result from any structural or functional impairment of the ventricular filling or ejection of blood. So it's either a filling problem or it's a squeeze problem. It's basically what it comes down to. So this in the United States is a huge problem. So 6.2 million Americans have heart failure of some sort, some variety of heart failure. You can see it is a disease of the aged, right? So in men ages 50 to 59, the incidence is 8 in every 1,000 males in the United States have heart failure. When they get to 80 to 89 years of age, now it jumps to about 66 for every 1,000 males in the United States have heart failure. So the older you are, the higher the incidence of having heart failure. And unfortunately, when we look at race-based distributions, it is very disproportionate. And there's lots of things that kind of go into that. But you can see this is something that really impacts our country. 80% of patients admitted for heart failure are greater than 65 years, and they will die within 5 years. Estimated cost, $34.4 billion each year in the United States to treat not only heart failure, but the complications related to it. Okay? So a huge, huge, huge burden on society And when we talk about the causes of heart failure, the vast majority of them are preventable. They're lifestyle choices that we make that puts us at risk of developing heart failure. Because we've already talked about in our last blog about hypertension and coronary arterial disease being somebody who is obese, smoker, diabetic, poor diet, high fatty foods, all those things put somebody at risk of developing this condition. So if we can manage those conditions, prevent those conditions, then we can prevent the majority of heart failure cases. Now we talked about heart failure is a cardiac output problem. But remember that there's more to just cardiac output, okay? There's a lot of factors that impact that cardiac output. So heart rate being one. If I have a heart that's failing because my heart can only beat at 30 beats per minute because my conduction system is too damaged, and now I'm relying on the bundle of His or somewhere outside of the SAAV node to drive that heart rate, that's going to lead to a cardiac output problem, right? If I have a stroke volume problem, that's going to have significant impacts on my cardiac output. And remember, you have preload contractility that have a positive effect on stroke volume, meaning the higher they are, the increased stroke volume you're going to have. But then also your afterload, which has an inverse relationship where the higher the afterload, it drops your stroke volume. Okay? But all of those factors lead to a cardiac output problem. And if you remember from our first block, we showed this pressure loop. In a normal heart, systole starts with the closure of the mitral valve, and then you get that squeeze of the ventricle, that pressure starts to increase without any additional volume until that pressure gets to the point where that aortic valve opens, and now you get that flow of blood out of the heart, and you start to lose that volume as the ventricle continues to squeeze and generate an increasing pressure to the point where now that volume is so low that even an additional squeeze of the ventricle is not going to increase that pressure, and you start to have a drop in your pressure to the point where now the aortic valve closes, diastole starts, and now all of your valves are closed. The ventricle is relaxing, so you're dropping your pressure without changing your volume at all, until that pressure gets to a point where now the left atria pressure is higher than it is in the ventricle, and that mitral valve opens, and now you get that flow of blood back, or that flow of blood into the ventricle, which increases the pressure slowly. So that is a normal pressure loop. But if I manipulate any of the three factors that go into stroke volume, you can see we can have a pretty profound impact on those variables. So if I increase my preload, I'm going to be able to add all this additional work, all this additional effort to it. The inverse is true as well. If I drop my preload, I'm going to shift that curve, that pressure loop, over to the left. If I increase my contractility, I'm now able to inject more blood per heartbeat, and so I get increased work in that way. And then again, the opposite is true. If I decrease my contractility, I'm going to decrease my stroke volume. I'm going to decrease that work because of that. If I increase my afterload, I start to lose all of this work because that valve is going to close at a much higher pressure, much higher volume remaining in the ventricle than it should. So I'm losing all that effort. If I decrease my afterload, then I shift that thing over again. I get kind of a delayed closure of the valve, and now I'm adding work to it. So remember how those different variables impact your stroke volume, which will impact your cardiac output. This is just a flow chart that kind of shows how they work. But let's focus in on the contractility and the preload components of stroke volume. Okay. So your lines on the graph here represent your contractility. So normal contractility is this curve here in black. If I have somebody who's had a coronary, has a myocardial infarction and I lose a large portion of my left ventricle, I'm not going to be able to squeeze as hard, right? So I'm going to drop that curve down. And then if I am on a medication, or if I am somebody who's physically active, does a lot of cardio aerobic activities, and now my heart can generate a much more powerful squeeze because of my physical conditioning, you can see that in the green line here. And this looks, okay, what's really the significance of this curve? Well, let's add that if I were to have my preload to a point where now I'm increasing the preload, and any time I get to preload to this level, I have pulmonary congestion, because I'm going to have a backup of the fluid from the left atria and into the lungs. So anybody who falls into this range is going to have pulmonary congestion. Let's drop now look at the y-axis, and let's drop that stroke volume to a point where in this box here, if your stroke volume is down at this level, you are going to have hypotension. So you're not going to be perfusing things properly. And now you can get an idea why these patients are at risk of heart failure when they start to have symptoms. Because if they have decreased contractility, that window of them still being able to function without symptoms is very, very small. So any kind of stressor, anything that impacts that cardiac output, even the slightest, could tip them over into an area where they have symptoms, whether it be hypotension or pulmonary congestion, or both. If I am somebody who is physically active, I have good aerobic conditioning, you can see now I have a lot more leniency and change in my stroke volume or my preload without having any kind of symptoms associated with this. So that's why being physically active has such positive benefits, because now you have all this additional reserve available to you that folks with diseased hearts don't have. Before we start talking about heart failure, we got to establish, well, what is a normal heart function, right? So we talked about cardiac output. Really the only true way to measure cardiac output is by doing invasive testing, right? So we've developed the ejection fraction measurement as an opportunity to do a non-invasive test to give us an idea of the function of the heart. With ejection fraction, you're not, every time that heart squeezes, you're not getting rid of 100% of the blood that's in the ventricle. There's still going to be some left behind. But a normal ejection fraction ranges from anywhere from 50% to 70%. So that means every time my heart beats, 50 to 70% of the volume is going to be ejected out of the ventricle and in through the aortic valve aorta. So that's a normal function, normal EF. Now looking at heart failure, there's a lot of different terms that we can use to describe heart failure, okay? And we're going to go through each one of these to show what exactly each one of these entails. But when we look at the different causes or the different types of heart failure, there's different pathophysiologic things going on that's leading to this heart being in a failed state. So when we talk about a systolic dysfunction, or HFrEF, heart failure with reduced ejection fraction, ultimately what's happening is we're having that decreased cardiac output, okay? But that decreased cardiac output is actually because the ventricle does not empty like it should. So reduced ejection fraction. So now instead of a 50 to 70% ejection fraction with every heartbeat, maybe I'm only at 30% gets ejected out of the heart, okay? When I talk about diastolic dysfunction, or HFpEF, heart failure with preserved ejection fraction, You still have a decreased cardiac output, but it's because you're not filling that ventricle during diastole properly. So now the ventricle is going to squeeze whatever blood is there, but I'm not going to give it a lot. So I'm not going to give it the volume it needs to actually generate a reasonable cardiac output. When I talk about left-sided heart failure, the symptoms I'm going to typically see are going to be things affecting the lungs, so pulmonary edema, pulmonary congestion. Right-sided heart failure is going to be peripheral venous things, so jugular venous distension, peripheral edema, gut edema. Those are going to be the typical signs you're going to see. If I talk about a low output heart failure, this is kind of the typical heart failure we think where you have that low cardiac output. High output heart failure, on the other hand, is disease states that cause the heart to function at a higher pace, i.e. things like infections, like fevers, things like increased levels of stress, where that sympathetic overdrive is going, so your heart's having to beat, 80, 90, 100 beats per minute instead of the 40, 50, 60 that it would normally at rest. And you basically just the heart just wears out. It can't keep up with that pace indefinitely, right? When you go and work out, there's a limited time that you're asking your heart to function at that high level, right? I go and I run for an hour. I got an hour, and then it's going to calm down. But if I'm in a high sympathetic, high stress, and infected kind of state, I'm now asking my heart to beat at 100 beats per minute, even when I'm sleeping at night. So you can imagine that wear and tear that's going to occur. It's not a limited time frame you're asking your heart to function at that high level. But let's look more in depth on each one of these terms to kind of clarify and help us understand why we see what we see, why is it we see these pathophysiologic things, and all that. So we'll start first with HFrEF, or systolic dysfunction, which is the vast majority of the cases of heart failure you're going to see. Because when we look at the causes of HFrEF, we're looking at things like coronary arterial disease. How prevalent is that in our society, right? And basically, things that can cause this type of heart failure are things that are the contraction and contractility of the heart is diminished or dropped. So things like heart attacks, things like mitral or aortic regurgitation, things like dilated cardiomyopathy, which we're going to talk about 2 lectures from now, all cause basically the heart to not squeeze effectively. The other kind of version of HFrEF that we're going to see is if this afterload is increased, especially dramatically increased. So things like you have poorly controlled hypertension. Now this is not necessarily like your 140 over 91. This might be like your 160, 170. Not even necessarily getting to the hypertensive crisis range for things, but if your heart's having to pump blood out against a systolic of 170, imagine how that's going to impact the function of the heart. Aortic stenosis we talked about yesterday, the most common valvular disease we're going to encounter in the United States. It increases that afterload because now you have all that additional pressure that has to be generated to just open the valve and get that flow of blood to occur in the first place. But ultimately what happens is I decrease my ejection fraction, I decrease my stroke volume, and that's going to decrease your cardiac output. And what I'm going to see then, because of that decreased contractility, I'm going to have an increase in volume left at the end of systole, which means my end systolic pressure is going to go up too, which then leads to when I am in diastole, and now I'm adding all that additional volume coming from the atria, I'm going to have an increased end diastolic volume and an increased end diastolic pressure. That's going to get translated to the left atria, which is only going to be able to tolerate that for a little bit before it backs up into the lungs, and now you get pulmonary congestion and pulmonary edema and all that kind of stuff. Okay. If I get other kind of things that can cause like reduced cardiac output, so I have some compensatory changes that develop related to it. I'm going to have like shortness of breath and chest pain, and even the arrhythmias, because I'm adding all this stress to the conduction system because I'm stretching that conduction system inappropriately. And kind of a perfect example of that was, well, that pathophysiologic effect is the clip that we showed today with I Love Lucy. When those chocolates started coming too quickly, what did it start to do? They started packing the chocolates in their hats, in their uniforms, eating them, throwing them on the ground, and everything like that. And that's what the body does when it starts getting this backup. It starts to pack away all this extra volume, all this extra fluid, anywhere and everywhere it can to try to preserve that function of the heart. Now let's talk about diastolic dysfunction, or HEF, heart failure with preserved ejection fraction. Now, oftentimes there's a lot of confusion. If I am in a failed heart, how am I having preserved ejection fraction? It comes down to the math, okay? Now, we said that this is not the ideal way of determining the function of the heart, but the only way that we can truly assess the cardiac output is by doing pretty invasive testing, right? So we're limited by our ejection fraction. And when we look at the math of this, let's say in our failed heart, our end diastolic volume, because we are not going to fill that ventricle normally, let's say that that's 4. Our end systolic volume, because you're going to squeeze whatever blood out that gets to the ventricle, because that ventricle is going to generate that extra squeeze, right? Let's say that that's 1. So, that's going to be then 3 over 4, because my end diastolic volume is 4. So 3/4 times 100 is 75%. Okay. So 75% is my ejection fraction. That looks good, right? Although we said normal is like 70, but this is just math. But let's compare that to a normal functioning heart, okay? So let's say that our end diastolic volume, because it's able to tolerate all that volume, all that preload, is 10. It's going to eject whatever blood is there. We'll say that that's 1. That means that it's 9 over 10 times 100, so 90%. Okay? So both not reduced, both normal, both look okay, but why is it that this one is in the heart failure category? And it comes down to, now we got to take this and calculate our cardiac output. So my cardiac output is, so we said, so stroke volume is end diastolic volume minus end systolic volume. So basically this in the parentheses of your EF. So 3 in this diseased heart, so 3 times 60, we'll say is the average heart rate, is 180 milliliters per minute. Okay. But let's now do the normal heart. So we said our stroke volume was 9, so 9 times 60 equals 540 milliliters per minute. So look at that delta between the normal heart and the diseased HEF heart. Will your body suffer from that difference of 540 milliliters per minute to 180 milliliters per minute? That is a significant difference, and that is what is going on with HEF, that preserved ejection fraction. Yes, your ejection fraction is normal, but the downstream effects, that cardiac output effect of that is very abnormal. Right. will your body be able to tolerate that cardiac output? And the answer in a lot of these patients is no. So does that make sense why this is preserved ejection fraction but still heart failure? But when we look at kind of the causes, so we said that HFpEF is due to impaired ventricular filling. Think about the things that cause that filling problem. So it could be you have left ventricular hypertrophy. So the muscle has gotten thicker because it's had to deal with such higher pressures that now it's not going to stretch and accommodate volume. It's going to be very limited in what it can tolerate. We'll talk about these conditions in 2 lectures from now. But we talked about constrictive pericarditis or tamponade. Remember how we talked about how those conditions limit that dilation of the ventricle. So you're not going to be able to tolerate all that additional volume with it. So what are going to be kind of the presentation symptoms and stuff like that you're going to encounter with this? Well, if I'm not tolerating all that volume that's supposedly coming back from the lungs into the left atria, does it make sense that it's going to back up into the lungs, and now I'm going to have all those pulmonary symptoms associated with this because of that backup? When we look at left-sided heart failure, and this could be, these terms can be used together. So this is not just an isolated, you can only have a left, you can only have a right, you can only have a HFrEF, you can only have a HFpEF. You can use these in combo with each other. So you could have, say, a left-sided HFrEF, okay? But left is just, the left side of the heart is the problem. So things like coronary arterial disease that knocks out a large portion of the left ventricle myocardium is going to lead to a functional problem, right? Hypertension we talked about, other kinds of things. We'll talk about like our toxic cardiomyopathies and how those can impact function of the left side of the heart. When we talk about right-sided heart failure, though, the most common cause of right-sided heart failure is the left failed first. And it's just backing up into the lungs, which then adds additional pressures in the pulmonary vascular system, which then goes over to the right and starts to affect the right side of the heart, the function of the right heart. So that's the most common cause of right-sided heart failure. But if I'm going to look at, so kind of think of it like that as a secondary cause of right heart failure. But when I look at primary causes of heart failure and I break up those 3 things that affect my stroke volume, you can see the different kind of pathologies that can cause right-sided heart failure. So if I'm going to talk about an afterload problem, so I increase my afterload, think of there's problems with the pressures either leaving the right ventricle, so like pulmonic stenosis, or the pressure in the lungs, the blood vessels in the lungs themselves are too high. I have that increased afterload. And now I've got that resistance of flow, and the right ventricle has to work harder in order to get the flow to actually occur in the first place. When I look at increasing my preload, so things like pulmonary or tricuspid regurgitation, where I squeeze out the blood, but then it comes, a lot of that comes right back because of those valvular diseases that are present. I no longer have that one-way valvular integrity or that one-way flow. A lot of that volume comes back, and now the heart's having to work again to get rid of that volume that's already there and that it already got rid of. If I decrease my contractility, so think of things like I have a right-sided MI, right-sided myocardial infarction, that took out a lot of the myocytes of the right ventricle. So now I can't generate an adequate squeeze of the right ventricle to get that blood flowing out of the right side of the heart. Low output failure. So basically, think of this as low cardiac output, and we've already kind of hit this. But high output failure is the heart's able to generate a cardiac output, but it's got to do it at such a high rate for such an extended period of time that it wears out the heart. And the heart just cannot keep up with that pace long enough. So treating fevers with Tylenol will decrease the tachycardia and decrease the overdrive that the heart's having to experience just simply because of that fever. So those are the different types of heart failures. Now, why is it that every time we get the flu, we don't go into heart failure? It's because our body can compensate, at least briefly, for stressors like this, right? We're young, our heart is relatively healthy. It can accommodate, it can compensate for those stressors. And there's a lot of different ways that the heart can actually accommodate or compensate for this. And it's a tightly kind of regulated system, which is great because you don't want this to be inappropriate. However, the problem with this regulatory system is it's almost like all these organs go into self-preservation mode at the expense of the rest of the body. So like the kidneys. I'm not getting the perfusion I need because I got renal artery stenosis. So what am I going to do? I'm going to increase my volume. I'm going to try to increase that blood pressure. Well, oh, by the way, the brain's already seeing a blood pressure of 300, right? That's bad, right? It's going to cause stress. It's going to cause trauma to the brain. But the kidneys are just trying to get what they want, right? Our nervous system, sympathetic, parasympathetic nervous system, it's going to tightly regulate this. But again, maybe, like, okay, if I need to increase my cardiac output by stimulating the sympathetic nervous system, what's that sympathetic nervous system going to do to your vascular tone? It's going to constrict it, right? So now I'm increasing my afterload and my contractility. Am I really fixing my cardiac output problem by doing that? Because that afterload has a negative impact on it, right? So you can kind of see all these different systems, all these compensatory changes, they try to do what they think is necessary to fix the problem, but they're actually not identifying the true cause of that problem to actually fix that. So let's look at kind of the compensatory changes that can do this. So when we talk about like acute things that every second I can change or I can adjust, and then the chronic things, which is like think about like a permanent change that occurred, a permanent compensatory change that occurred in order to fix this failing heart. So we'll talk about the acutes first. We're going to first talk about Frank Starling. We talked about Frank Starling, where as I increase my preload, I'm going to increase my contractility, which ultimately leads to an increased stroke volume. Sounds great, right? I can adjust from beat to beat according to this. The problem is, I get to a point on Frank Starling where now my stroke volume actually starts to go down because I can't handle that additional volume anymore. So I start to lose that strength of contraction. Kind of think of it as if I'm going to do bicep curls and I'm starting from here, okay, I'm only really limited, I'm really restricted, right? If I do a full thing, okay, I'm generating a lot more power. But now when you go all the way back here, and now I'm hitting, kind of trying to get that thing to come back up, that's basically what happens. I've stretched that myocardium too far, and now I can't generate the power that I need to squeeze that blood. Sympathetic nervous system. When I stimulate that sympathetic nervous system, what's going to happen? I'm going to get that increase in the strength of contraction, so that contractility is going to increase, and I'm also going to increase my heart rate with it, which sounds great. But in a diseased heart, where I don't need this stimulation for maybe just an hour while I'm working out, but I'm in a diseased heart where I'm having to have this stimulation at such a high level for an extended period of time, the response starts to decline. So I get a down regulation of that response So now, when the sympathetic nervous system fires and says, go faster, the body's not going to really listen to it because it kind of starts to tune out that stimulation. So now I don't have that effect that I need from that beat to beat kind of modulation because it's just tuning out the sympathetic nervous system. Now, when we look at the neurohormonal axis, this is where a lot of our problems start. Because most of the neurohormonal responses, compensatory changes, actually lead to furthering the problem of heart failure. Okay? So how is the neurohormonal system activated? Well, you have all these pressure baroreceptors kind of spread out through the body that are checking on the pressure that's coming to it, and it's going to regulate that hormonal response based on what it feels. So like, the carotid baroreceptors, but you have them in other locations where it will trigger that hormonal response. And one of the key things that it kind of tends to do is it activates the RAS system, or the RAS. That's redundant. It activates the RAS, where now I'm increasing my volume because I'm trying to hold on to all that fluid. I'm reabsorbing all that sodium. But if I have a preload problem already, and now I'm adding volume to it, I'm only making that preload problem worse. We're looking at our Frank-Starling curve, and now I'm shifting that preload over to the point where now my stroke volume starts to deteriorate or decline because I've pushed it over the threshold. Other hormonal kind of responses, the antidiuretic hormone produced by the pituitary gland, that causes the kidneys to reabsorb extra water, and that can increase the preload, which increases the volume overload and everything like that. And there's a lot of different kinds of neurohormonal kind of changes that occur, and the pathophysiologic effects of them can have some pretty profound effects that ultimately will lead to pulmonary edema and pulmonary congestion. Sounds great, right? So what's some additional kind of hormonal things that, compensatory changes that occur? Endothelin 1, this is a local potent vasoconstrictor that is secreted by the blood vessels themselves. So it comes from endothelium. And what happens is the blood vessels sense that the pressure maybe is not great because that cardiac output's down. So what am I going to do? If the pressure is the problem, let me just vasoconstrict and increase my pressure. But what does that do in the afterload? It's increasing it as well, and now I'm dropping my cardiac output even more. So we're trying to fix a very focused problem without actually considering the complications, consequences of doing that action. And you can see what happens with this. So you have depressed ventricular contractility. So I'm reducing my cardiac output. That triggers that neurohormonal activation, which causes like the secretion of endothelin 1, for example. That increases my vascular resistance. I increase my outflow resistance. That's then going to affect my cardiac output even more. And then that's going to trigger some additional neurohormonal activation. You can kind of see this spiral. And this could be a death spiral if you don't do anything about it. Fortunately, there's one neurohormonal activation that actually has an idea of what's going on in the grander scheme of things. So it actually gets released and triggers positive, beneficial compensatory changes, okay? And that's your natriuretic peptide. So BNP, pro-BNP, atrial natriuretic peptide, ventricular natriuretic. So lots of different kind of versions out there, a lot of different naming schemes from it. But these peptides are released in response to atrial or ventricular stretch. So basically, if I increase my preload, in the atria or the ventricle, this system is going to identify that it's getting stretched. It's then going to release these peptides into your bloodstream. And you can see what ends up happening is, if this is a volume overload problem, let's start getting rid of volume. So let's start excreting sodium in the water. Let's block the RAS system to prevent additional volume overload, right? Let's also stop the effects of aldosterone, which also has an additional kind of volume control problem. Let's stop the effects of angiotensin II, which yes has an effect on the aldosterone release, but it also, if you recall, angiotensin II has a direct vasoconstrictor component to it as well. So I'm going to block that vasoconstriction. So now I'm decreasing my afterload problem to try to improve my cardiac output. I'm also going to cause a vasodilatory effect itself. So it has a local vasodilation. It kind of does the same thing where it decreases afterload. And then the vasopressin, I'm going to stop that antidiuretic hormone action. So now I'm going to additionally secrete volume out appropriately. So you can see the natriuretic peptides, the things that we test to tell us if this person's in heart failure or not, is truly the only thing that actually can fix this problem outside of the medications we give to our patients. Some additional compensatory changes that develop. You may see on a echo the description of concentric hypertrophy, which think of this as a compensatory change that occurs at the muscular cellular level, so at the myocardium, and it's a reaction to excess pressure. If I have excess pressure, I have to generate additional or higher pressures in order to get that flow of blood, right? So I'm going to hit the gym and I'm going to become a bodybuilder, which is great because now I can generate that pressure. How flexible do you think that person is? Probably not. Ask them to do yoga. It's probably going to be a comedy watching them do downward dog, right? Because they're not going to be able to, because that mass is just too large that it affects their flexibility. So you can see this could be something you see in a diastolic or a HEF patient. Now on the other side, if I have a volume overload problem, you can get eccentric hypertrophy. And this is because that stretch is just so much, because that volume is just so much, I developed this compensatory change at the myocardial cell level in order to decrease that stress, that stretch. But unfortunately, kind of think of this as like a rubber band that gets stretched too far, and it's not going to rebound back to its normal size. It's just going to be kind of stretched out, floppy, and maybe not be useful anymore. And that's what can happen to the myocardium if they rely on this to deal with that extra volume. And the pathophysiologic effects of this is, okay, if I have that concentric hypertrophy, so I'm increasing the cells for strength because of that pressure overload, now I'm not taking all that additional volume, and that can lead to the failing of the heart. Whereas in the volume overload state, in the eccentric hypertrophy, I get a proportional increase in the ventricular chamber's radius, the size of the chamber, but then I start to lose function with that. And here's kind of a graphic of what we mean exactly by concentric hypertrophy and eccentric hypertrophy. So concentric, so we said the pressure overload, I need to generate a higher, more powerful squeeze. What ends up happening is, here's your normal myocardial cell, and you can see, okay, maybe there's 4 or 5 kind of myocytes in this cross section here to generate that strength of squeeze. But if I have to generate a more powerful squeeze, what I'm going to do is I'm going to add additional myocytes in this particular area to help me generate a more powerful squeeze. And you can see that increases the width of that one cell, which then starts to impede on the lumen of the chamber itself, and you start having that stiffness, that stiff ventricle developing, even though it can generate a much more powerful contraction. When I get eccentric hypertrophy, now what I'm doing is I'm trying to lengthen the size of that myocardial cell by stacking these sarcomeres in parallel in series, and I'm lengthening that cell. But again, think of that rubber band that's stretched too far. I don't get a powerful squeeze, even though I can tolerate that additional volume before that pressure starts to go up. And when we look at the pressure loop changes of this, you can see the impact of it. So we said in HFrEF, you have that eccentric hypertrophy, and what ends up happening is I can tolerate a higher preload, so I'm shifting my curve over to the right because I can tolerate that higher preload, but I can't generate that powerful squeeze anymore. So my pressure that I can generate is going to drop significantly. And you can see ultimately what happens to my pressure loop is it's down and to the right. So I can tolerate the extra volume, but I'm not generating that squeeze, and I lose stroke volume. Because look at this stroke volume compared to the dotted line on a normal pressure loop. When I have HFpEF, and I have that concentric hypertrophy, I'm able to tolerate and generate a higher squeeze, so that pressure is going to, I can generate a higher pressure, but I'm not going to stretch, I'm not flexible enough, so my preload moves over to the left, and ultimately my pressure loop goes up and to the left. And now I'm losing all of this stroke volume. And the other implication of it is because I'm not going to stretch to accommodate that preload coming in that does get in, my pressure rises quickly, a lot quicker than in the normal pressure loop. So that's why, even though the heart thinks it's doing what it needs to in order to function, it's actually not fixing the problem, and it's actually making it worse. Let's go ahead, take 10 minutes, we'll come back and talk about acute. So we just talked about the various forms of heart failure, and we talked about how it's affecting the cardiac output, but that doesn't necessarily mean that they have symptoms even though they have a reduced ejection fraction or they have preserved ejection fraction. But what happens when we're on, remember that chart I showed you with contractility where I had those red boxes that showed where symptoms develop. What happens if I have that diseased heart and now I shift one of those variables, preload or stroke volume drops, and now I get into that symptomatic range of that chart? That's where acute decompensated heart failure comes in, where now I start having symptoms, and typically profound symptoms, because of that failed heart. And there's lots of things that can cause somebody to teeter from that chronic kind of, maybe I'm controlling my HFpEF or my HFrEF, to now I need to be in the hospital because I can't breathe right, or my cardiac output is so low that I'm not thinking clearly, or whatever, meeting the basic metabolic demands. And you can see, using the acronym HEART FAILED can kind of give you an idea of the wide variety of conditions that can teeter somebody over the edge to where they need to be in the hospital as opposed to being at home. And lots of things could be it. Unfortunately, what do we have at the end of this month? Thanksgiving, right? Holiday heart is a real problem. You are working inpatient Thanksgiving or the week after Thanksgiving, you are going to be inundated with heart failure exacerbations. So if you work in the ER, you're going to be seeing a lot of patients coming in. If you work on the floor, you're going to be taking care of these patients. Because part of that heart failure kind of diet is low sodium, decreased, healthy options. Maybe your volume needs to be restricted a little bit, right? But what do? We eat turkey. It's probably been brined, which means you have lots of salt, right? You have stuffing, which has lots of salt. You have green bean casserole, lots of salt. So people who normally are like, maybe I'm only eating about 1,000, maybe 1,500 milligrams of sodium in a day for my proper diet, now eat 4,000 or 5,000 milligrams of sodium, and that triggers that volume overload to occur. So holiday heart is a real problem. The other cause of holiday heart is alcohol consumption. So New Year's is right around the corner, and lots of people, of course, drink excessively, and that triggers heart failure exacerbation. So this is the worst time to be working in the hospital because you're going to be inundated with heart failure. And all of your patients are going to look like this. This is the typical appearance of somebody who is experiencing an acute decompensation. Because they have all that excess fluid in their lungs, they're going to be upright because you want gravity kind of cause that fluid to drop into the bases of the lungs to increase the surface area of your alveoli and everything like that to oxygenate. They're going to have gut edema. They're going to need some assistance for respiratory, so they might be on CPAP or BiPAP even. They could even be intubated to help with oxygenation while you work to get rid of all that extra fluid. The other thing you can look at their arms there. They look quite large to me. You don't see their legs, but it could be that their legs look like this. And you got that pitting edema, where you could probably get FBI fingerprints done based on their legs. Okay, I pressed the wrong one. So it can be pretty profound. And from experience, these patients will not just come in with like a little bit of fluid overload, right? We say about a gallon of water is about 8-point-something pounds, right? I had a patient who gained 50 pounds in 2 weeks from fluid. So that tells you 50 divided by 8 tells you how many gallons of excess fluid was on their body. Because it's just third spacing. It's putting it anywhere and everywhere it can to try to restore that cardiac output to function normally. So they can come in very profoundly fluid overloaded, and they're just sitting there. You might as well just put a catheter in, even though we don't like using urinary catheters that much because of the risk of infection, because they're going to be getting up and peeing every 10 minutes or so if you don't. So, but yeah, it can be pretty profound fluid overload. So what is it going to look like when the patient comes in with an acute decompensation? So we said it's that symptoms, right? So if it's a left-sided problem, think about all the pulmonary problems, okay? Also think about some exertional problems, so exertional chest pain, easily fatigue, exercise intolerance, because your cardiac output will not be able to increase to meet that demand to keep that physical activity going. If we have right-sided heart failure, which remember we said what's the most common cause of right-sided heart failure? It's the left that failed first, right? Well, the right-sided heart failure, the symptoms and the physical exam findings you're going to see are going to be things related to peripheral venous congestion. So the peripheral edema like you see in the legs here. One caveat would be is that fluid's going to accumulate in gravity-dependent areas. So if somebody is on their feet for long periods of time, yes, it will accumulate in the legs. But if they're in their hospital bed with their legs elevated, where's the gravity-dependent area now? Back in the buttock area. So maybe that's where they're pitting edema. So you may be falsely reassured by, oh, your legs are not pitting anymore, we're doing great. But then you look at their backside and it's all there because it went to that gravity-dependent area. So don't be falsely reassured by that. Other signs of right-sided heart failure could be because of gut edema, because the abdomen can tolerate a lot of third spacing of fluid. It could be they just don't have an appetite anymore. They don't want to eat anything because of that gut edema that's present. What else could be? Well, if it's a cardiac output problem, maybe they're not going to meditate properly. So they're not going to be alert and oriented times 3, right? So don't document on your physical exam alert and oriented if they're disoriented. Urinary habit changes. So you think, okay, this is a volume overload problem. You would think that I'm going to be urinating a lot to try to get rid of that. But if I don't have the cardiac output to perfuse my kidneys, not only am I not using the filter properly to get rid of all that extra fluid, but remember what our compensatory changes are. The RAS gets activated, and part of that RAS is to retain water. So now my urinary output drops even more, which just makes the condition worse. So I'm not getting rid of that extra fluid. And then waking, I told you kind of that example of one of my patients. But it is profound how much weight these folks can gain. So in physical, what are you going to see if you're focusing on just left-sided heart failure things? You're going to be thinking things about the lungs. So maybe they're going to need tachypnic because they're trying to breathe faster. There's going to be crackles on auscultation of the lungs. There could be an S3 or even an S4, kind of depending on this HFrEF or HF. For right-sided, you're going to be right-sided heart failure. You're going to see that jugular venous distension. You're going to have like that hepatojugular reflex that we kind of talked about. Could be positive as well, where you push up on the liver in the right upper quadrant, and then you see that jugular venous pulsation wave go up because that right side of the heart's not going to tolerate that additional volume being forced out of the liver and up to the heart. So now, when you go to diagnose somebody with acute decompensated heart failure, there is a scoring tool that I don't like, which is why this is an FYI. But it's called the Framingham scoring tool. And we don't really use this too much. We typically think of acute decompensated heart failure more of a clinical diagnosis. And you can see when you look at like the individual values that go into calculating somebody's Framingham heart failure thing is weight loss of greater than or equal to 4.5 kilograms in 5 days in response to treatment of presumed heart failure. So you have to presume this patient has heart failure and treat heart failure before you can actually diagnose that it in fact is heart failure. Does that make any sense? Not at all, right? That's a major criteria. And then, okay, a minor criteria could be weight loss of greater than 4.5 kilograms in 5 days. Without treatment, necessarily. But you can see kind of how this has kind of a limited utility because I got to presume that this patient has heart failure and treat it before I can actually officially diagnose it. And oh, by the way, I've got to give it 5 days. So it's not very useful. But what is useful? What can you do? Well, let's do laboratory testing. So there are lab values that we can do. We can do a chest x-ray, especially a left-sided heart failure. You're going to see that pulmonary congestion and everything like that, right? Let's do an EKG and make sure that it's not because this is like this person suffered a heart attack and now they're having this post-MI complication related to that heart attack. Let's do an echo because I want to know, am I dealing with a HFrEF or a HFpEF problem? We'll talk more about kind of the management, more about the management side of things tomorrow based on this chart. So what laboratory studies can I do to help me with my diagnosis of my patients? Well, let's just do the routine things. Let's do CBC and see if they're anemic. Let's see if there's evidence of an infection that triggered this acute decompensation. Let's check their complete metabolic panel, because not only am I looking at the kidney function, not only am I looking for electrolyte problems, But I also want to see what's the liver doing. Because if the liver's not being perfused properly because of that reduced cardiac output, does it make sense that I'm going to release my stress things, so my ALT, my AST are going to go up because I'm not perfusing that liver. Let's look at the thyroid, because thyroid disorders can precipitate heart failure. Iron studies, because when there are a lot of other things like liver disease and stuff like that that can trigger this. Cardiac enzymes, let's make sure that the patient didn't suffer a heart attack. Let's do their BNP, pro-BNP, because remember, this is the only neurohormonal response that the heart does that actually takes care of the real problem. So if that's elevated, that's telling me that this is somebody in heart failure, and it's also telling me the degree and severity of their heart failure and the body's response to try to fight back and kind of gain control over the situation again. But the other additional benefit of a pro-BNP, BNP is testing for those natriuretic peptides is this is the one true test that I can do that can help me determine, is this a cardiac problem leading to the symptoms the patient's having, like the dyspnea and all that kind of stuff, or is this a pulmonary problem? Is this their COPD acting up? Is it they have a pneumonia or something like that? Because this value will only be released, these values will only be elevated in settings of the diseased heart, because it's that atrial or ventricular stretch that causes the secretion of these things. So this helps differentiate cardiac causes versus pulmonary causes. When we look at like the values, when we look at a BNP, which obviously this is going to be kind of like your medical facility specific, but just kind of giving you a rough estimation. If I'm looking at BNP, anything greater than 400 is consistent with heart failure. Normal is less than 100. When I look at pro-BNP, there's an age range that kind of determines what normal is. And unfortunately, that's not as easy, but kind of think of it as if you're less than 50, anything greater than 450 is elevated. Let me add 25 years, so age range of 50 to 75. Let me double that value, so I get double that amount. Anything greater than 900 is now abnormal. If I'm now over 75, let's double that value, and now it's anything over 1800 is considered abnormal. Okay. But pro-BNP is going to, the normal value is going to be dependent on age. Other diagnostic studies that you can do, let's do our chest x-ray, let's look for that pulmonary congestion. You may get like the curly B lines and all that stuff, right? You learned about cardiology radiology last semester. You may see an enlargement of the heart. You may see some additional complications related to an acute decompensation. And there's lots of things that you can kind of see on this. The vasculature kind of looks fluffy, but kind of compare that to this one. Just look at that pulmonary congestion that's there, to include curly B's and curly A's and all that. Let's do our EKG. And although there's not a typical EKG finding for heart failure, let's make sure that they didn't have a heart attack that triggered this, because we may need to bring them to the cath lab if they just did, right? But this will kind of give you an idea also of other causes that could have contributed to the acute decompensation, i.e. an arrhythmia developed for some reason. I lost my P waves because, and I lost my atrial kick because I have AFib now. How is that going to impact my preload, especially in somebody who has HFpEF, where I am really dependent on that atrial kick to actually generate any kind of volume in the ventricle to begin with. So do they have an arrhythmia that needs to get treated in order to improve their condition? Echo, 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 echo. If you had to choose one test, echo would be it, because I need to know what am I dealing with exactly. Am I dealing with a HEF, or am I dealing with a HEF-REF condition? And then what are some of the functional impacts because of this failed heart? Do I have wall motion abnormalities because it's stretched too far out? Or do I have a wall abnormality because they just had a heart attack and now all of those myocardial cells there are dead because of that heart attack? Now, we'll finish up our lecture today talking about the classification system. I hate memorizing things just for the sake of memorizing things. I feel like if you're going to memorize something, there's got to be a reason to it. Unfortunately, this is one of those situations where you just have to memorize this because your testing, your standardized tests, will describe a patient to you and ask you what's going on. And you just have to be able to determine, is this somebody who's in whatever heart failure stage, or, you know. So this is something, the next two slides are just something that you're going to have to memorize. And I apologize for that, but yeah, it's necessary. So when we go to take care of a patient with heart failure, we've got to be able to clearly communicate what type of heart failure they have and what their functional impacts are because of that heart failure. So functional impacts, we use the New York Heart Association, so NYHA classification to tell us what the functional impacts are of their heart failure. When I have somebody who is considered NYHA class 1, they have no limitations. So they have heart failure, but they have no limitations whatsoever because of that heart failure that they have. They can do whatever activity they want, and they're not limited by their condition. When we have class 2, or mild, you get a slight limitation of physical activity, but they're comfortable at rest, but ordinary physical activity results in symptoms. So normally they can walk a mile and they're fine. But now they're fine at the 3/4 mile mark, but when they hit a mile, they start having symptoms. So that's now that ordinary physical activity triggers symptoms. Compare that to class 3, or moderate, which is now they have significant or marked limitation, and they're comfortable at rest, but less than ordinary activity causes them to have symptoms. So now it's, instead of it being their mild or normal range, now it's half a mile they start to have problems. They start to have symptoms related to this. And then compare that to severe, class 4, which is they're unable to carry out any physical activity, including at rest. So this could be just them laying in bed, they have symptoms, where they turn over, roll over in bed. Just that causes them to have symptoms. So that's an NYHA functional classification. Now compare that to the ACC-AHA staging classification, because this is where a lot of our treatment guidelines are going to come from that we're going to talk about tomorrow. But a stage A heart failure patient is the presence of a risk factor, but they have no heart disease and they have no symptoms. So technically, if anybody here has hypertension or have diabetes, you technically are stage A heart failure, according to the ACC-AHA, because you're at risk of getting heart failure. Stage B heart failure is now you have heart disease present. So this could be a structural thing like left ventricular hypertrophy. It could be a functional thing where now your ejection fraction has dropped below the normal range. But in spite of those things being present, you have no symptoms. So you've never had symptoms before related to heart failure. Your body's able to, your heart's able to generate at least a cardiac output that meets the demands you put on your body. When we move up, stage C, I still have that structural heart disease, but now I'm having symptoms. This is the key thing that delineates a B from a C, is that symptoms are present in stage C of that heart failure. And then stage D is advanced heart disease with continued heart failure symptoms despite the medications we give to treat the symptoms. So our best treatment modalities are not working to control your symptoms at all. And you may be wondering, well, how do these kind of work together in our classification? You can kind of see this stepwise approach. The color relates to the NYHA classification, and then the ACC-AHA screening kind of show you as you go up the different marks. So usually, okay, a stage A, you can see doesn't meet the NYHA classification at all. It's just manage your risk factors, right? But when I get to stage B, and now I'm a class 1, now I'm going to do kind of these treatments. And we're going to talk about the management guidelines tomorrow. But you can see as you move up the steps, not only are you moving up the ACC-AHA staging guidelines, but you also are moving up the NYHA functional limitation as well. So, and by the time you're getting into stage D ACC-AHA, you now are reaching that class 4, that severe functional limitation. So that's how those two kind of play a role or interact with each other. And we'll talk about tomorrow with the management, where it talks about NYHA 2 to 3, you're going to do this. If it's 4, you're going to do this, and those kinds of things. So, questions on the pathophysiology of heart failure? All right. That's all I got for you today. I'll see you all bright and early tomorrow morning as well.